Okay, so we are now live, and so we should be able to.
Oh, sorry.
Okay, well, I still think we may be actually live. So we have questions coming in, Susan. We've got about 30 or 40 really actually excellent questions coming through. Um, and so we'll start seeing people kind of come on. I think to the right of your screen, you'll see people coming through. And so as we see people coming in, I'll introduce us all. We got some great questions though that were submitted beforehand. And so we'll go through some of those and we'll see how it looks here. I'm going to look on my other screen here and see how it looks. And let's see. Waiting for live video. So I think we're live. I'm just waiting for, oh, there we go. There we go. So Tammy's on. Hi, Tammy. So anyway, we're live here with Dr. Susan Eckerling, who's an emergency medicine doctor that I work with here in North Carolina, and Dr. Peter Hogenkamp, who's family medicine in Vermont. And we're going to be taking questions. And we have a bunch of questions that were submitted. And so if you want to type questions, please do. I'm going to move myself over so I'm a little bit closer to the camera. And I'm gonna read a couple of the questions that we've got already. So the first question we have is from Terry Renker. Does wearing masks wearing masks protect us the best? Seems there are varying opinions, and we've talked about masks quite a bit. And really, Susan, show us your mask. Your mask, that's an N95 mask. That one actually does protect us because that's N95. It protects you from breathing in the virus, and that's a mask that's actually protective. Yeah. The cloth masks, the bandanas and things like that, they are not really protective of breathing in the virus, but they're protective if you happen to be asymptomatic and transmitting the virus. Hopefully it's going to reduce transmission and protect you from giving it to somebody else. And the idea being that we're going to sort of be a good neighbor and not give it to other people. So it's not really protective as much as protecting you from giving it to other people. Would you guys agree with that?
Absolutely.
Yep.
So the N95s are really for healthcare providers to not kind of give it to, get it from our patients, but the people that you see out in the streets and things like that. And I don't believe that wearing it out in the streets does anything. I think your risk outside in the world is really, really low.
No.
The idea is I put it on when I walk into the store because I'm trying to be a good neighbor, and I take it off as soon as I go outside because, the fact of me, remember, we've talked a little bit about exposure plus time is what gives you the virus. And if, if you don't have a bunch of exposure, you're not close to somebody, you're not going to get it.
Jeff, there was just a good question about the dental office that just popped up.
What was that?
It says, how safe are patients at a dental office?
Oh, great question. What do you guys think about that?
Well, two of my best friends are dentists, and they're still out of work because they've been out for 12 weeks until they can actually figure out, how to do it safely. And I think they're going to start next week, but there's a lot of exposure at the dentist. I mean, you're very close, and it can be for an extended period of time. So I think the dentists are going to come back, but they're going to be well garbed up. And once they do that, I would be fine with going to the dentist. But I think as they were, I think that probably wasn't going to wash.
Hey, Peter, do me a favor. Move to your right, like 6 inches, or your other right, I guess. Yeah, there
we go.
Again. So listen, right next to our office, we have an orthodontics office, and they reopened Monday, I think. And so this is what they do. They actually have parking spots that are numbered, and people pull into the spot and they text, and then they have somebody that comes out. And Susan, it looks like they're getting ready to intubate somebody. They're fully garbed, fully gowned, face shield, mask, everything, and they go out and they get the kid. And the kid gets a mask put on him, and they take him inside, and I think that they're fully garbed up, and they do the procedure. They take the mask off the kid. They're hygienists, and it's an orthodontist office, and they do their thing fully garbed up, and then the kid gets delivered back out to the car afterwards. So they're going to the nth degree, and they're wearing N95 masks and everything. So they're going to a pretty good amount of precaution at their office. And so that's my personal experience with it, which is pretty impressive.
To do that, because clearly we're starting that have been putting off their dental emergency and now they really need help.
They do. Mm-hmm.
It's going to need to do like we do and guard any procedures with face masks and gowns, and then guard them in between patients.
Oh, hey, listen, let me explain the bait and switch to everybody, because I told people, different doctors, we have different doctors on. So Dr. Kirchhoff, who's an emergency doctor from Indiana, got pulled away and had to cover a shift. And Dr. Bream, who's going to be with us, Susan, what happened with Dr. Bream? His wife went into labor and she's going to have a C-section like in the next hour. So congratulations and best of luck to Dr. Bream. We're excited for them. And Dr. Ectorlin was kind enough to step in for us. So that was unintentional bait and switch, but we're very happy to have Susan on board.
He managed to catch still in the office that day, because I was supposed to get off 2 or 3 or something.
Yeah, that's right. So anyway, somebody, Catherine asked, is it safe to have a CT scan with contrast if both patient and tech are wearing masks? If the tech is talking while you're in the scanning table, any risk there? And I think that's probably pretty safe. Again, we're talking about a little bit of distance. The tech, when you're doing the scan, is really only close to you when they're setting it up. When they're actually doing the scan, they're going to be in the control room and be isolated from you. So I think that's pretty safe.
Somebody asked me the other day if there was any good things that were coming out of this COVID, and I said, there really is. And one of the things is our hospital has completely changed all their cleaning procedures.
Oh yeah.
And I tell people right now, getting a scan, they're cleaning everything between every patient, and they're actually thinking about infection control all the time. So in a lot of ways, this is a very safe time to go in. Now, does that mean it's 100% safe? No, but I would have no problem about going to get a scan at this point in time.
Yeah, I agree. Our cleaning folks are awesome, aren't they?
Right. And they're appreciated nowadays, let me tell you.
Yeah, they really are. I mean, they're awesome anyway, but they really are superstars now. They're
Jeff, here's a good question about flying. I'm curious about your thoughts about flying.
Flying. So, flying, I think, the air, I talked about this a lot way back when it first started. Somebody asked this question and we did a video about it, but the air in airplanes is quadruple filtered. So probably the air supply is pretty good, but it's proximity. We talked about proximity, infection equals exposure plus time. And if you're sitting quietly near somebody, you need about 1,000 virus particles to get infected.
Right.
And how quickly you get that exposure depends a little bit on proximity. So if you're sitting in a room with somebody who's infected, with at relatively close proximity, let's say 4 or 5 feet, it may take about an hour, 50 minutes or so. If that person is talking, then the exposure goes up by a factor of 10, so maybe 5 minutes. And if they're singing or yelling or exerting themselves like in a gym, it might go up even farther. So
Absolutely.
in an airplane, if you're sitting there next to somebody and they're talking right next to you, I think that's dangerous. So if there's not somebody in the middle, if there's somebody right next to you, I think that's risky. If that middle seat is occupied, I'd be a little bit nervous about that. Mm-hmm. And we've seen pictures of these cross-country flights, and the airlines are trying to maximize what little profit they can make or what little revenue they can make. And if there's someone, if they're packing those flights in there, I'm worried about that. I would want to see that middle seat unoccupied.
Which I think it is, yeah.
Yeah, but I don't know. I've seen pictures of full flights. Have you guys seen that, where people have posted videos of full flights?
One of my patients just got back from a trip, and all the middle seats were kind of closed off.
Yeah, I think if the middle seats are unoccupied, I'd feel much more comfortable.
Me too. Yeah, for sure. Yeah.
I think Spirit was the one recently that there wasn't any. They were really starting to pack all the seats, so there was some question about letting people know ahead of time what exact occupancy was of the plane, and people could make their choice whether they felt it was safe for them to fly.
Is Spirit the one that they give you the goggles and the scarf too?
I don't know.
The open cockpit, is that Spirit? That might give you a little extra protection. I don't know.
The question here about hip surgery, and about whether that's safe to do hip surgery. And I would certainly feel, if it were me, I would go get my hip surgery, no problem at all. As I say, in our particular area, and we've talked about this before, Jeff, how sometimes these decisions need to be made a localized. I happen to be very fortunate to live in the state with the lowest amount of COVID in the union. And right now, our hospital, is COVID free. We've only had a couple of new cases in the last week in our whole state. The hospital is being cleaned twice a day. I would go in and get my hip surgery today with no fear. Now, I probably wouldn't do that if I were living in metropolitan New York.
And I think if you're getting a procedure under general anesthesia, that's a closed system that's cleaned. I wouldn't be worried about general anesthesia either. Would you? I don't think I would be concerned about that. Would you, Susan?
No, I don't think so. It becomes, you have to consider, of course, if you needed to go into, say, a nursing facility rehabilitation or something like that, I'd probably hold off because I wouldn't necessarily want to be in that setting. But if it was a straight surgery, go home, I wouldn't have worried there.
Yeah, I agree.
There was a good question here about a lady who had Addison's disease. And I think it kind of speaks to all those folks who are high risk, who have comorbid medical conditions. And moving forward, I think young, healthy people are going to probably, start their lives again more quickly than those people who have medical problems. And I think that's an actually good structured way to do it. For instance, my 91-year-old mother probably is not going to, do too much at this point in time until possibly a vaccine's out or we have some type of a better handle on the situation. But my kids who are, 25 years old and perfectly healthy, even if they were to get the disease, probably wouldn't get that sick. I think those folks are going to probably start moving along now pretty quickly.
And we've talked, Peter, we had a conversation about this last week that, it's not fair, right? If you have a chronic medical problem, it's not fair. And
Nope.
People have messaged me like, it's not fair that, if you say, well, healthy people can go back to work, I'm not healthy, it's not fair. And you're absolutely right. But the virus doesn't care. The virus doesn't care what's fair or not. All it cares to do is propagate. But,
right.
We've got to move people back to work because poverty is just as dangerous. It's going to kill just as many people. And
or more.
We've got to figure out some balancing act to protect the people who are at most risk while also protecting the people who are at low risk. And we've got to figure out what that balancing act is and try to balance both ends of the scale and do it in a way that's, and understand that, I know it's not fair. It's not going to be fair. I wish it was. I really do. But unfortunately,
Here's a good question about what's the purpose of an antibody test if you can get COVID a second time? And I'm interested in your thoughts on that, Jeff.
Yeah. So, we've certainly started to see these reports of a second infections. Now, remember, we've had, close to 5 million cases worldwide, and we're starting to see a smattering of reports of second infections. Now, you would think that we would have seen millions of second infections if
Correct.
That's really the case. So
Yeah.
Are these actually second infections, or are these maybe reactivated infections or maybe partial infections that never fully resolve? So I don't really know what the answer to that is. We also know that there were some studies that I reported on maybe a month or two ago of people that they looked at antibody response, and they showed that there was a subset of people that really had a sort of a suboptimal antibody response. And the conclusion from those papers were that, maybe there are some people that don't really generate a great antibody response, and they might be at risk of having another infection. Whereas most people develop enough of a response that they're going to be probably immune. So maybe what we're seeing are these sort of poor responders that maybe they had a minor infection and they didn't really get a great response the first time.
Right.
And so now they're getting sick again. But the other thing we're not seeing is that they're not getting like deathly ill either.
Right.
We're not seeing like people getting like a minor infection and then ending up in the unit. It sounds like they had a minor infection and then maybe getting another minor infection. So I think that the antibody testing is still a pretty good way of knowing whether you've been exposed or not. And now we finally got accurate antibody testing. Just this week, I had we use LabCorp at my clinic, and I've had a lot of people asking me to get antibody testing, and I've been refusing to do it because I didn't have the answer of how accurate it was.
Right.
And Alice, who's our LabCorp rep, who's really pretty fabulous, I keep asking her the same question. I said, Alice, would you test your family members? Nope, I wouldn't do it because it's not accurate enough. And last week she said, yep, we got the Roche test. It's 100% sensitive. It's 99.9% specific. We're doing it. So
that's the same test that we use. It's 100% sensitive. And so what that means is, so sensitivity is if you have 100 people that have the disease, it will pick up all 100 of those people.
Exactly.
And we rarely have things that are that sensitive. So I think it's a very good test.
Exactly. And so that's what I was waiting for. And I actually said to our emergency medicine group, hey, we're going to do it. And then I didn't say anything because I didn't really have a good test. And I think just this week, Susan, I said, if you guys want to do it, we actually got a good test now. And I wasn't willing to actually offer it until I felt like it was a good test.
It was a good test. And speaking of tests, there was a great question in here about the other test that we use, and that's the nasal swab that we use to test for people who have active infection. And that test is a lot trickier because what they're doing is they're looking for actual parts of the virus. And as many people have pointed out, smartly, that test is considered to be about 60 to 70% sensitive, which goes to show you the difference in some tests. And someone was asking me, why would we even do that? Well, number one, if you get a positive test, you have your answer. But if you get a negative test and the patient still has the signs and symptoms of COVID virus, I still diagnose people with the problem. You following me?
Yeah. And that's, and I think that gets to some of these conspiracy theories like, oh, we're calling people COVID that's not COVID. Well, remember, we're past the flu season. Right. And there aren't a lot of other things that cause this kind of spectrum of things. And Susan, you and I have seen this a bunch of times where we've got patients that are deathly ill. They've got the pathognomonic bilateral infiltrates. They've got, like I had a prisoner who had all these medical problems, had the bilateral infiltrates, hypoxic, and his test was negative. And I admitted him, like, he's definitely got it. And the inpatient doctor's like, yeah, he's definitely got it. We'll recheck him because our sensitivity at that time, the PCR was only 60%. Now, I think our new test is 95%. Is that right, Susan?
Yeah. That's what I've been. But
right. They're better for sure.
Got a newer test that's more sensitive, but initially they were like, we knew that 40% of the positives were going to be negative. So, things change as we go along, but why don't we speak to that? Like, have either of you guys felt like you were pressured to diagnose things that you knew were not COVID as being COVID?
Absolutely not. No.
Never.
No.
And I think that's something that people think. The other thing is like this business about reimbursement being like that we're going to get paid $13,000 if we diagnose somebody with COVID or 40 if we intubate them.
Really?
Yeah. Right.
Well, I wish that were true.
Yeah, I know. And I think what people don't understand is that hospitals get paid based on a diagnosis. So if a person gets admitted with a pneumonia, the average amount of money they get paid is about 13 grand. And out of that, everybody gets paid, doctors, the medicines. And if the hospital can spend less than that $13,000 for that patient by being more efficient, then they get to pocket that, and that's their profit. If they spend more, then they have to eat it.
Right.
And
it's just incentive for them to get the patient treated efficiently.
Right. And it's not like the doctor gets to pocket 13 grand by putting a diagnosis on that. That would be fraud, and that's not. So let's go to some of these things. Tammy's got a question about going to her neurologist next week. She's been quarantined the entire time. Do you think that she should go, and how should she protect herself? What do you guys think?
That would depend upon where she lives and what the COVID kind of penetration rate was. Here, like a couple of weeks ago, we were doing mostly video visits. Today, Jeff, I saw everyone came to the office. I saw 23 patients all in the office, and I think everyone felt safe. If she lives in one of these hot spots, I would probably not go and I would postpone it. If you're in an area of the country where there's low penetration rate, I would have no problem about going to the neurologist. Again, using a mask, washing our hands, social distancing, all these things that we've been talking about.
And I happen to know Tammy, and she's actually in an area that's pretty low prevalence, so I think it's probably okay. Someone's asking about antibody testing for people who were sick with COVID-like symptoms earlier this year. I say do it. The testing is inexpensive. It's accurate now. If you think, go ahead and get it done, because if you come back positive, then presumably you're at much lower risk of getting of
COVID.
getting. I think if you had symptoms in December, it's going to be very unlikely that that's what it was, but
right,
it'll give you some peace of mind. Right.
Yeah. I mean, I think, the whole medical machine works on information, and the more information that we can get, the better off we are.
Absolutely. Let's see here. I was near someone last Friday, and then they were diagnosed with COVID-19 yesterday. She seemed fine when I saw her. Do I need to be tested? Now, that's a great question, Lynn.
Good question.
Lynn Robinson asked that question. Now, Lynn, I think you do need to be tested, because we know that people can be asymptomatic and still transmit the virus for up to a week before they develop symptoms. And so if it was last week, your friend may have been symptomatic or asymptomatic, but still contagious. So I think that you are in a risk group, and I would talk to your doctor and get tested. Would you guys agree?
Yes, absolutely. 100% agree.
Yeah, the flip side of that is if you're not working out of the home, and depends on your environment, but if you just self-quarantine, you could probably eliminate testing, but self-quarantine.
You have to self-quarantine for about 2 weeks.
Right.
Yeah, that's true.
The only thing that's good about having the information is still the epidemiology, seeing what kind of, it's contact tracking and prevalence and all those things. So there's some usefulness in the information for us in the medical community.
Contact tracing is something that Peter and I were talking about before the broadcast started. And I think that there is, what is contact tracing? And, I think there's fear in terms of privacy and kind of, again, conspiracy theories about contact tracing. But, contact tracing is very important when we're dealing with an outbreak, a pandemic, epidemiology, because contact tracing allows us to track infections and to track contacts of people who are infected. And if you don't do contact tracing, these infections tend to get out of control.
Out of control, right.
But there are very real concerns about privacy and other things. Now, South Korea, which, their citizens don't really enjoy the privacy protections that we do, just contact tracing. They just do it by their phones. They don't care what their citizens think, and they've been able to control the infection very effectively, because they've been able to call people up and say, hey, you were exposed, you need to stay home. And if you don't stay home, they're like locking you down. And obviously that's something that's a difficult pill to swallow here in the US, but it would be nice to know if you got exposed. So what are your thoughts about what's the appropriate way to do that in a free society? Tough, right?
Well, I love the idea of using the cell phone technology to do this. I mean, it's very accurate, and we're going to see there's a lot of apps that are coming out. But the issue is that it's going to be voluntary, and I personally think a lot of people are going to say, you know what? When I weigh my privacy concerns versus the concerns about my life, I think a lot of people are going to opt in on the cell phone technology, and I hope they do.
And to think that we're not being tracked now. I mean, I was a few months ago, I was looking to buy a new vehicle, and, oddly, that brand of vehicle kept following me to Facebook and to Google, and every website I went to, mysteriously, that brand kept popping up. I wonder why that was. Almost like someone was tracking me. Things that make you go,
Yeah, you every time you touch on a site, they're tracking you. So
right.
I think it's foolish to worry about your privacy with it. I mean, we've been doing it for decades with sexually transmitted diseases.
Right. Absolutely right. Yeah.
So it really, it's all helpful information, like you guys said before. We really, really need it so that we can make more accurate decisions.
So let's try to get to some more of these questions. There's a couple of ones we can answer pretty quickly.
A lot of good ones here.
PPE in hospitals, I think we're doing pretty good.
Mhm.
I think that the hospitals are much better prepared now than they were 2 months ago. Wouldn't you
Which
agree?
is good.
Absolutely.
Yeah, we are a much better place now. A question about travel sports. What do you guys think about sports, kids and sports? Travel softball.
I have 4 children, and they all play sports, and they all want to get back to them. So I might be a little bit biased, but I think that, I think we have to do it smartly. But I think to just shut down all sports is going to do a lot of damage in the long run. We have to look at that. Not that I want to pack people into soccer stadiums right at this point in time. But I think to just say we can't do any of this is kind of myopic. And so I say we get back to sport, especially sports that are outdoors.
Right.
They have a natural advantage. Now, basketball is a tough one. That's where it all started. That's when the NBA got the COVID virus. That's what started the U.S. from being locked down. And that basketball is a germy thing.
Oh, here's a great question. What are your thoughts about going to a chiropractor who sees multiple patients a day and doesn't wear a mask? Boy, that would be a vector. I would not go back.
No,
that is irresponsible. I'm sorry.
Yeah. Yep.
They're getting exposed. They have a responsibility to their patients to protect them. I'm sorry. I don't, you need to, they don't know if they're getting exposed. We don't go to see our patients in the emergency department without a mask on.
No. Jeff, I don't like wearing my mask. I do it as a benefit to my patients. I wash my hands before and after every patient, and I wear goggles and a really nice mask, and I'm doing it for the benefit of the patient, not me. So I wouldn't go back to that I wouldn't go back to that person.
No, I wouldn't either. I think sports and the other one is gyms. Like, we're going to phase 2. There's a couple questions on here about phase 2 and North Carolina is going to phase 2 of reopening gyms. And I did a talk about infection. And in infection, we talk about exposure plus time. And, if you're so where are the riskiest ways to get exposed? Indoors, close proximity, heavy breathing. So there's a great example of the choir in Seattle. Oh, yeah. One infected person, 65 choir members, 45 people got infected singing. So a gym, close proximity, lots of breathing hard, high risk. Yeah. Now, Peter, you said outside. So your risk if you're outside is a very, very low. Your risk inside is very, very high. And so I think that gyms, especially, I do CrossFit, I think that's high risk, unfortunately. I think if you're in a place that's bigger, that has higher ceilings, that can open up garage doors, like that's what needs to be done to get air moving. If it's a small place, like some of the group fitness places are really pretty tiny, I think they're at high risk. And if they can move those classes outdoors, that's probably the safest thing to do.
Absolutely. Jeff, one of the reasons that, a lot of these viral illnesses have a seasonal component to them is, when in Vermont now it's 75 degrees here and everybody's outside and spacing out. And these things, they tend to, the flu starts here in November when everybody goes inside and gets close together. And I agree with you about those gyms. There's several gyms in our town they're tiny places. They got 10 people packed into a small room. That's risky.
And I think we've seen, case reports of transmission from classes like that overseas places. Let's take a look at. So here's an interesting question, and Peter might be able to speak to this more than us. My daughter had Kawasaki disease as a toddler and is 13 with asthma. Any risk of getting inflammatory symptoms like Kawasaki's again? And I'm assuming if she got COVID. I don't know if there's any evidence of that inflammatory Kawasaki-like syndrome recurring if you had Kawasaki's before. I don't think there's any data that shows a risk of getting it a second time. Any thoughts on that, guys?
I have no thoughts about that. I will say this, because I have a lot of people ask me about Kawasaki's disease. And I think it's come out of the fact that it's been well played in the media as a response to people saying, well, kids generally aren't at risk for the serious case of this illness. And I still think that remains true, Jeff. What was the number of Kawasaki's case that they had? It was not a great number.
I think 40 in the New York area,
Right. Right.
I mean, I
Less than
personally
100.
seen a tiny number in my career. Susan,
Right.
have you seen many in your whole career? Oop, we lost Susan.
I've seen one case of Kawasaki's in a 25-year career.
I've seen one, one severe one. I've seen Kawasaki like. Let me get Susan back here. Oh, let's see. Oh,
there she is.
There she is. Hey, Susan, you're there? Well, she's coming back, I think. Anyway, it's very, very unusual, very rare. So I think it's a low risk, but I would think that just because your child had it before, I don't think it puts it at any higher risk.
Yeah. There's a lot of questions here about school, and as a parent of 4 kids, obviously that's something on my mind. And I would really like to see the kids go back to college in the fall. As we've talked about before, in general, these college-age kids are very low risk. And obviously, the concern is that, they'll be spreading the disease to people who aren't low risk. However, I think what we have to do moving forward is allow the kids who are low risk to go ahead and live their lives, and at the same time keeping these other folks, like your grandparents and things like that, so that they're actually more protected. I don't think we can take all people as one size. One size doesn't fit all.
And they're an ideal group to get infected, right? I mean, college dorm, what a great, if you want to get herd immunity developed, let the college kids get, Susan keeps trying to join, and I think she's struggling. She's in our little doctor's office in the hospital, and the Wi-Fi there is a little sketchy.
The Wi-Fi is sketchy, yeah. But you're right, Jeff. That's a great way to start building herd immunity, which we're going to have to do.
Yeah. The only problem with college students is the landlords or the professors that, might.
There are the grandparents when they go home over Christmas.
I'm trying to let Susan join us again, but.
So a couple of the colleges in Indiana have decided that they're actually going to open in the fall, but they're going to do it in a peculiar way. They're going to start early. They're going to go straight through, no breaks, and then they're going to finish.
I saw that, end at Thanksgiving, right?
Right, and then the kids will be able to go home. They can self-quarantine for 2 weeks while they do their exams and reading period, and then they can, if they're okay, then they can go out back to the normal world, see their grandparents, and see the other people. I think we're going to have to take some risk to move forward.
So, I've seen a couple questions about, getting together. Like, if you've quarantined and you've got friends who have quarantined, can you get together? And, it's sort of the circle of trust, right? Like Meet the Fockers. Like,
oh yeah.
If you've been quarantining and your family members have been quarantining and
right.
you're pretty sure, then you guys are all safe. Like, if everybody's been quarantined for 2 weeks, then yeah, there's no reason that you couldn't get,
right. I agree with you. You have to trust that other person that they've been actually doing it appropriately.
Yeah. And the same thing with friends. Like, my son and his girlfriend, after they were, they were apart for about a month and they were completely, locked down. And finally we talked to her parents and they were like, she hasn't been anywhere. And well, he hasn't been anywhere. So we let them see each other after a month.
Yeah.
So, I think that's, reasonable as long as you're pretty, comfortable with that quarantine. Same thing with parents and if you're good with that 2-week quarantine, I think that, we're at the point now where you can sort of get back together a little bit. But
yeah, because I saw some more definitive data on that now, and they've now identified the longest possible exposure risk is 12 days.
Yeah.
So if you're doing 2 weeks to be safe, that is pretty much guaranteeing that you're not going to be transmitting that virus.
Yeah, I saw 95% of symptoms show up within 10.7 days.
Yeah.
So
in my particular practice in Vermont during late March and early April, when we did have some COVID in Vermont, we actually had 22 positive cases in our practice. And I will tell you that the lion's share of them, those people got infected within 2 or 3 days of exposure to a person who had it. It was not long.
No. And so, I think that those, if you are pretty confident, I think that that's reasonable. There are some questions here about, so this lady, Jean Eckert, says that her mom has significant scoliosis, hasn't seen her physical therapist in months. Pain is getting worse, wants to have an adjustment. If the therapist wears a mask, she wears a mask, they have good hand hygiene, and she's face down during treatment, you think that's enough for her to go to get an appointment? And I think taking reasonable precautions,
absolutely.
especially, I think in that case, I would really want the therapist to be wearing an N95 mask, not just a cloth mask.
Yeah. I just had a recent case of a patient I've taken care of for years, and he came in with, sounds to me, well, he was having angina. He was having exertional chest pain and shortness of breath. So I sent him to cardiology, and they agreed. Unfortunately, all the testing was postponed at this point. So he didn't get the stress test, the echocardiogram that he would have had. And about a week later, he had a massive heart attack. That would have all been prevented. And I use that to illustrate the fact that so all postponing some of these things and doing all these things, or not doing all these things that we normally do, has an effect to it. And so there's a danger to not doing as well. There's a danger to quarantine.
Absolutely. Hey, besides, I want to give a shout out to Peter. I'm going to see if I can do this cool thing here. Besides being a family medicine doc, let's see if I can do it. Peter is an author as well, and he has a book that just came out called The Intern. It's on Amazon. And so if you guys want to check it out, I'm trying to put it up on the screen, but I don't think I can.
Geez, Jeff, if I had known this, I would have brought a copy.
Anyway, I don't know why I can't show it. Sorry, man. I was trying to give you a plug.
That's okay. It's the book is called The Intern by Peter Hogenkamp. It's available on Amazon. I'd love to hear what you think. I'm if you read the book and you want to talk to me about it, I'd love to hear comments on Facebook.
Excellent. So let's go on to some other questions here. So Lisa Seal said, should I send my daughter to college? Yeah, definitely send her, because your college age daughter, you want her to get it. You really do want her to get it, because she's not going to get seriously ill. The risk of someone who's 45 or less, who's healthy, of getting like so seriously ill with this. I mean, there's a minuscule chance, but your risk is less than getting killed in a car accident in a year. So those are the folks we really want to get exposed.
There was a really interesting question about ballet classes. And I thought it was good because, this woman was talking, her kids really want to go. And I think it's healthy for these kids to go. These are great activities, healthy activities for the kids. And I think you can do it. She said they're going to put 4 to 10 kids in a class, depending upon the size of the room. The kids are going to wear masks. And the other thing I would say is parents, and we just have to learn to not do things if we're sick. I think the expectation, in the workplace in our country for years has been you go to work regardless. And, I'm here to say that that's been the expectation in my office as well. But we have to change that. So when people are sick, they work from home. I think that's a good option. And if we use these common sense techniques, Jeff, on your videos that I watch every night at 3 a.m. when my wife turns them on, hand washing, wear your masks, social distance when appropriate, think about infection in your head now. It's become part of our psyche. I think we can do a lot with just those simple measures.
I think you're absolutely right. You can use common sense. Think about others,
Right.
Think about I always say, look out for yourselves, look out for your families, look out for everybody else. Just be decent human beings. If we look, if we do those things, we are going to get through this, with as little pain as possible.
Jeff, you say that on your video, and I love that. Be good to your family, be good to others. So many of my patients who are elderly have come and told me that people just come out of the woodwork to help them. I'll bring you groceries. I'll do this. I'll do that. People have been wonderful. And I really think, in terms of flattening the curve, we have done a wonderful job of that in the United States, particularly in certain spots. And one woman was asking, is this all a waste of time and resources, what we've done? Are the same number of people just going to die anyway? And I think the answer, and I thought that's a good question. There's certainly a lot of people that ask me that same question. And I would say that I think we have saved a lot of lives. I think ultimately, the people are going to get exposed to this virus. But if people get exposed to this virus when the hospitals aren't jam-packed, people are there's more PPE out there now. and we're learning more about the illness. We're getting closer to a vaccine. There's talk about some medicines that are treatment. So I think it's all been worthwhile. I really do. Having said that, I think we do need to start opening things up, in a sane and scientifically based way.
I agree, and and I think that it is important that we start doing it in a reasonable way, and keep testing so we know that if things start spiking again, and people have been asking some questions about a second wave, we think that very likely that things may taper off in the summer, and then we may get a second wave. We're starting to see
Right.
that there may be a second wave happening in China, and that's likely to happen because until we achieve this sort of herd immunity levels of exposure, 50 to 70%, it's very likely that we're going to have a recurrence. And we may see that we need to lock things down again at some point. Um, do, right now, do we know when that's going to happen? We don't know. We think maybe in
No.
the fall that's likely. You remember, this is a novel virus. We don't know how it's going to respond. We don't know what's going to happen. And
We don't know if like the flu, it will mutate. I just saw a great question about getting someone's hair done. And I can certainly feel for that person who wanted to get their hair done, because I feel like I've gone back to the 70s with this hippie hairstyle I've got.
Yeah.
Unfortunately, hairdressing, there's a lot of time and exposure there.
Yes, there is. And I think that like spa treatments, hair, nails, those are all very, close. We have an aesthetic side of our business, and my esthetician keeps saying, when can I come back to work? And I don't know like what protocols we're going to use to keep her safe and keep our clients safe. And so, I've got to think about that, because, face shields and N95 masks for her. We've got to, I don't want to, take any chances at all. And and also, like, she's not used to taking those precautions. And so there's going to be a training piece before we ever reopen that side.
Right. And you make a good point there, especially for the aesthetic side of the business, which by definition is elective. Now, if somebody's having chest pain, obviously that changes the calculus a little bit, because now all of a sudden they've got a life-threatening illness anyway. Right. And that's one of the interesting things about this pandemic, Jeff, is that we are seeing fewer heart attacks are presenting to the hospital, fewer cases of appendicitis. Where are these things going?
It's true. And, we're starting to see in the emergency department, numbers volumes coming back up with these people
Right.
that we're now saying, boy, why don't you come in for this 2 weeks ago? Well, I was afraid to come in.
But they were afraid.
People that, were looking and saying, well, I probably had a mild heart attack a couple of weeks ago. Now they're in heart failure. Mm-hmm. We're also starting to see, some post-COVID cardiac stuff that, I don't think is really well delineated. I talked about one of the videos where I had a lady who came in and with heart failure 2 weeks after she was in the hospital for COVID, that had never really had heart failure before, but had a lot of risk factors. And you wonder, like, was it just coincidence that she just developed heart failure out of the blue, or was it related to this other infection? And I think there's, again, we're learning every day from this. And are we going to see a wave of post-COVID cardiomyopathies or other things that we didn't see before? Somebody said, is it, talk about herd immunity, is it time, let's see here. Is it time to let our children have play dates and sleepovers so they can be exposed potentially? Sheila, maybe. I think that this is the rub. Like, I think, should kids go back to school? Probably. Like, for herd immunity, do we want to get kids exposed? But this is the elephant in the room, right? Kids are at low risk, right? But the problem is, who are the kids going to expose? It's the grandparents, like parents that may have medical problems. Like, that is the big problem. So kids are going to go to school. They're going to expose each other. It's a cesspool of bugs. And,
it is.
When your kids went to school for the first time, they got all these viruses, and it's a great thing because they got these viruses and then they get immune. So all those, when kids go to daycare, they get sick they get sick all the time for the first year. And then they're like, they're like supermen and women because they never get sick afterwards because they're immune to those viruses.
Right.
The problem with this is that they're going to bring those
It's
things home.
novel.
If their families are relatively healthy, then yeah, they're going to bring it home and their parents are going to get mildly ill or not get ill. But if that parent is sick or they've got cancer or they're immunocompromised or grandmother is the one that's raising the child or watches the kid, then we've got big problems. And so how do you balance that? And so that is the question. And I don't, I wish I had an answer for it. There is not a great answer for that. So ideally, yes, let the kids go back to school, get them exposed, let's get herd immunity going. But I don't have a good answer for
There's
it.
no perfect answer. And I agree with you, Jeff. There's no perfect answer. Someone just asked a question about immunocompromised 5-year-old going to kindergarten. Now that's a tough one there because I want that 5-year-old to go to kindergarten because I think it's good for that 5-year-old's intellectual and in social development. But that child may want to stay home for a year until a vaccine's out. That might be a reasonable thing.
Yeah, and there are a number of questions here about immunocompromised kids, and I think that that's great advice. Is if you've got a child who's immunocompromised, be safe, keep that child home until we've got a vaccine, because they're at higher risk. And in terms of there's a number of questions about who's at high risk, and people are at high risk. We think are people are immunocompromised if you're on chronic steroids, if you've got chronic pulmonary disease, COPD. I'm not really sure if asthma by itself, like mild asthma, I don't think is.
It actually wasn't. It actually was shown that it wasn't one of the top 10 risk factors. Yeah.
It's not really. We do think that obesity may be a risk factor. We think that might be why we're seeing more younger cases of severe COVID in the US. So obesity may be a risk. Certainly diabetes. We think that hypertension is a risk.
Which is interesting. Yeah.
Those are typical things, but immunocompromised certainly. Active treatment for cancer would put you in a risk group. Someone asked about what do mild cases look like. Well, they're going to, the problem is that a mild case is going to look like any other of a million typical respiratory things: cough, low-grade fever, congestion, GI symptoms, diarrhea, maybe a little bit of nausea,
muscle aches,
all those typical things that could be COVID or 10 other viral infections. And there's not a real easy way to tell.
There isn't. I had a couple that actually picked up COVID on the way home from the Philippines. And what was interesting is one of the patients, the husband, had multiple medical problems, multiple comorbidities. He barely had any problems at all. He said it was the mildest cold he'd ever had. His wife, who's perfectly healthy, got very sick and had to be hospitalized. So as much as we think we can predict who's going to get sick and who isn't, every once in a while, there's a little bit of a loop thrown to you.
Exactly. And we don't have a way of predicting that.
We don't have 100% way of predicting it. No.
I would not recommend that we do chickenpox parties for COVID at this point because we don't know.
Nope.
And, someone asked about teachers. Yes, teachers are going to, are going to get exposed as well. And that's the other, reason that we've got to be really careful about reopening schools. But, I think especially young children, I've talked to a lot of parents who have young children, and I think that a lot of people would agree that remote teaching of young children has been sort of a disaster, right?
Yes.
I mean, you can't really teach a first grader via, remotely. I mean, it's basically up to the parents to do it. And if parents are working and other things, it's very, very difficult. There are some age groups that remote teaching is very effective, and there are some groups that that's not effective.
Especially the younger kids, yeah.
Especially the younger kids, and also the socialization is so important. And I feel my son's girlfriend is a senior, and I mean what a loss for.
I feel for these kids, I really do.
I mean, gosh, and athletes, and it's like a lost year for these kids. And
absolutely.
There was a video I did that asked about people that know people that had the infection, and I couldn't believe how many people have been touched by this infection. And it's a real thing, and we've got to be cognizant of it. And many, many people have died, and many, many people have gotten seriously ill. We can't belittle that fact, and that if we don't take this seriously, many people are going to get seriously ill and potentially die. We've got to be careful. Other questions here. Outdoor gathering for worship. Yeah, I think that's outdoor is perfect. I think your risk outside is low.
It's low.
Social distancing.
Mm-hmm.
The church, I got mad in one of the videos because I went to the store and there were all the church right up the street from my house. The parking lot was packed, and I was like, oh, can't believe this. They're exposing all these people, and I was like a little bit mad. And as I'm driving back, I noticed like the cars were like, Eddie, can you turn it off? Whatever that sound is over there.
Was it a drive-in church?
And the cars were parked one space apart, and I realized they were all parked, and the preacher was outside with a bullhorn.
Yep.
I'm
yeah,
like,
people have been doing that. It's a great idea.
Yeah. So that was pretty. It was pretty neat. So outdoor church is great.
Jeff, how do you feel about school buses?
School buses, boy.
It was a good question that somebody asked.
Right?
Yeah.
Like almost like an airplane. Maybe keep the windows open. I think it's a little bit of a, but like a school bus is no worse than a school, right?
No, I would say it's very similar to the environment they're going to have in the school as well.
So James Dixie, why are so many doctors in countries across the world making claim that hydroxychloroquine is working early in the viral process, yet the media is against it? And that it's like the ongoing studies using it are set up to fail because they're using it with sick patients.
Right.
We've been using it from day one and haven't seen much effect. I have been recommending patients. I have a supplement sheet I've been giving to our patients, recommending people use, zinc and as one of the ways of potentially staving off viral replicase, and hydroxychloroquine can act as ionophore to help get zinc into cells, and that's one of the postulated ways of using it. But hydroxychloroquine can cause QT prolongation.
Mm-hmm.
And it's potentially dangerous, and I would be very hesitant to recommend it. And with Trump just taking it willy-nilly for no reason, I mean, I really want to see some studies that show it. I think it's we don't want to do harm for patients, and when you got a medicine that is potentially harmful, you got to be very careful making recommendations without good data to back it up. I've been recommending people take quercetin because quercetin is also an ionoform and is not harmful. There's no studies though. I mean, I think there's a lot of people that think it's curative. There have been no studies. Like, if it's really curative, there should have been at least some preliminary studies that show that, at least something. Have you seen any studies?
Yeah, well, it's interesting you say that because I had two comments on what you were saying. Number one is I've had a lot of patients ask me about this, and I simply don't know. And I say I don't know all the time, and I almost feel like I'm an uneducated physician, but that's because we don't know. We're trying to learn, and we are picking up a lot of things, but there's simply no data to suggest that hydroxychloroquine helps. And there were two studies that were done that were actually cut off by the ethics team because people were having side effects of cardiac arrhythmias.
Right.
So, our state came out and said, listen, do not use this. Interestingly enough, prior to this, I was talked into using it. Two patients who talked me into using the hydroxychloroquine. And in neither case did it help in any way. Neither one of them got sick, but both of them kind of had the normal course that they would have had anyway. So my N of 2 studies, and we all know that those small studies are dangerous, but in my small study, the hydroxychloroquine was ineffective, but not harmful.
Yeah. And they've been using it, and they continue to use it in our hospital for the inpatients.
Oh, is that right?
And, yeah. And they haven't, they were using it with azithromycin initially, and they stopped using the azithromycin because of the fact it just didn't work.
It wasn't helping. Yeah,
it wasn't helping. And it actually, I think, exacerbated the QT prolongation risk.
Right.
And so they stopped using it with the azithromycin. They're still using hydroxychloroquine as part of the protocol, but they haven't really noticed any improvements. But it's, I think people think we're not using it at all. The idea of prescribing it to people who aren't sick and the other thing is that there are people that actually need this medicine,
Yeah.
that have lupus, that have other problems. And if you just prescribe it willy-nilly, it won't be available for the people that need it.
Well, especially because the amount that you use is a lot greater than they would use for the rheumatologic disease. So we actually have had people having trouble getting it at the pharmacy, people that have been on it for years.
Yeah.
So that's a great point.
And Shayna asked, do you believe by the end of the virus, just as many people have died as if we had not put in place social distancing?
Yeah, I saw that one. Yeah.
And, I think that's the prevention paradox, which is, if you have a disease like this and you implement preventative measures and they're effective, then people look back and say, oh, we didn't need to do that because look, it wasn't that big a deal. So had we not done it, let's suppose we did not do anything. And instead of what we're seeing now, which is sort of like, oh, that wasn't that big a deal. Like,
right.
Oh, we destroyed the economy for nothing. Let's instead suppose the U.S. looked like Italy.
Mm-hmm.
We had overwhelmed the system and we had massive amounts of death. That would have been a very different conversation we'd be having today.
Or if the whole country looked like New York, look what happened in New York when they actually had to hire refrigerated trucks to store dead bodies.
So I think that social distancing did what it was supposed to do, which was to keep a scenario like New York from happening. And now it also allowed the medical system to ramp up. So now we've got this surge capacity. So even if we open up now and we do get a big surge in cases, our ability to deal with it
is much better.
How to treat these things.
I agree totally.
Much improved.
Yeah. Jeff, there's an interesting question about cruises. Do you think that cruises will be a safe option for vacation, at some point in time? And I have never wanted to go on a cruise because, I get people home from cruises all the time and they come into my office. And cruises are a great generator of productivity for me because people come in with GI illnesses all the time. They come in with respiratory illnesses. You've got 5,000 people into a tiny space. I'm not sure the cruise, that the whole kind of the calculus of the risk benefit situation in a cruise is ever going to be, to me anyway, positive. How do you feel about that?
I'm not booking my trip on the SS Petri dish. I've seen the same thing. Lots of people come from their cruise to the emergency department with their GI thing.
Yeah.
I think for the short term, like with COVID, the cruise ships are going to be a very dangerous place. They're always, people don't realize that, there's actually a subspecialty of emergency medicine that's cruise ship medicine.
Really?
I think the average cruise, 2 or 3 people die on average on every cruise for a variety of reasons, but there are lots of communicable diseases on cruises and they do their best job, but you're right. It's close proximity. And if an infectious disease starts, it can rapidly get out of control. I would think for the next year or two, I would not go near a cruise ship.
Here's a question that this person heard that nicotine helped with the virus. Have we heard any truth have we heard any truth about that? And I would say that what I've heard is just the opposite, that smokers are actually at higher risk for severe cases.
Yeah, especially vaping. We've had some vape-related injuries, and we had some cases early on of young people that were intubated with very severe COVID that we thought probably were related to heavy vape use. So I don't know. I'd have to look at, I'd have to do a literature review. But my gut feeling would be no, but I'd have to do some more research. A lot of questions about beach trips, nature trips. Are they safe? Hotels. I think beach trips, I don't think the beach is unsafe. I think you just need to be smart about it. If you're renting a house, I think that's very safe. It's just like quarantining at home, social distance. If you're reasonably away from people on the beach, I don't think that's a risk. Do you?
No, I think those are good ideas. And, I think it goes back to the point we need to move on. I think it's good for our national psyche. I think it's also good for our the medical machine costs a lot of money. It saves a lot of lives, but it costs a lot of money. And we need to get things going again, because otherwise, what's going to happen if we have to get rid of social programs? There's going to be a lot of pain. So, think about, I do like the idea of beach vacations. I think they're smart. They're outside. I like people on the golf course. I like people doing anything where they're not kind of clustered. Large groups of people aren't clustered into small spaces.
Yeah,
I agree.
hiking, anything outside. Here we have the Whitewater Center where water things, pools. We talked about is swimming safe? Well, chlorine's going to kill the virus as long as you maintain social distancing. Somebody asked about the bathroom at the pool. I think as long as you're washing your hands and you're not, you're being reasonably careful. I think that those places are relatively safe. Just use some common sense.
Right.
Remember, exposure. Prolonged exposure, close exposure to somebody is what's going to get you, plus time.
Somebody asked about the COVID-19 deaths, non-COVID-19 deaths being labeled as COVID-19 deaths. Actually, the opposite is actually more the case.
Yeah.
Because if you just looked at overall death rates during that period of time, the increase in death rates went up more than was explained by COVID. Actually, you did an excellent video on that, Jeff, that I happened to watch one night. And I think a lot of those deaths are actually going to be ultimately due to COVID. For instance, we were talking about the cardiovascular complications of the virus. Somebody who previously didn't have heart disease all of a sudden develops heart disease and dies of heart disease. Well, they actually died of COVID because the COVID is responsible for the heart disease that killed them.
And there's a question here from Elena Spiker, who I know actually, and she asked about DIC and these clotting disorders that we're seeing.
Yeah.
And people showering clots, and whether it may be PE or diffuse coagulopathies that are causing sudden death at home. And New York City saw this very big spike in unexplained deaths at home that are probably virus related.
Right, you'd think, yeah.
When we look at excess deaths, and it's not only in the U.S. we're seeing 20-30% increases in excess deaths. They're seeing it in Spain. They're seeing it in Sweden. They're seeing it in Europe. They're seeing it in Asia. These are very, very likely related to the virus, and we're probably significantly undercounting deaths from the virus because of this. And the virus has some weird, these weird coagulopathy related things. It binds to the beta subunit of hemoglobin. That's why we're probably seeing these really low oxygen saturation in these really sick people. There's a lot we don't understand about the virus, but I think we are probably undercounting, not overcounting.
We had we measure oxygen saturations all the time, and we had a patient. Normally when somebody comes in with an oxygen saturation less than 90%, that kind of perks us up. Well, we had a lady that came in at 40. And the amazing thing about it was she was talking to me. I mean, she was struggling a little bit to breathe, but 40. And that is really impressive.
What would you do if you were in the emergency department with somebody with a SAT of 40%?
Well, you'd want to tube them.
Right, exactly. And, and I've talked about that. That would be the right thing to do 100% of the time until March of this year.
Right.
Right. And then, now we would try not to do that. We would put them on Optiflow or something else, because we know that probably we can, maybe 40%, maybe not, but, we would try to not intubate that person if we could possibly avoid it.
If we could possibly avoid it, absolutely right.
Yeah. So let's see here. This is Nancy says, first grader was on teacher intervention, live videos. So yeah, Nancy basically saying maybe alternative arrangements for kids that have special needs. COVID toes phenomenon. Have you seen that in your clinic at all?
I haven't seen it at all. No, I've read about it, but I have not seen it. No.
Yeah, I haven't seen it either. I have read about it, sort of peripheral. As a matter of fact, I was watching if you watched John Krasinski's Some Good News on YouTube, and they were showing some videos of people leaving the hospital, and there was a guy who was leaving. You could see his fingers were all necrosed.
I've seen people have amputations as a consequence of it.
But, I think that that's probably a mild form of that peripheral vascular.
And the coagulopathy you talked about, yeah.
Yeah. Nancy was asking, was the person hallucinating at a 40% SAT? Probably not, right?
No.
I think it's more of a problem with the machine misreading. They're actually oxygenating pretty well. I think that's the point. They're not really at 40%.
They're not. The machine is telling you they're 40%, but they're actually not. No,
they're not really.
Yeah. It's interesting. Yeah.
People asking about gyms not opening for another. I think gyms are supposed to open this week. I don't know.
Not for us.
Huh?
Gyms are still not going to open here. Restaurants is a tough one because I love to go out to eat. I love to do it. And takeout isn't a big thing for me because, I like to go out to eat to get out of the house and see people and, that kind of thing. And
we had a patient in the office today who runs a restaurant.
Yeah, I feel bad for him.
They had to rent a trailer because they had to remove more than half of their tables to meet the 6-foot guideline. So they had to cut their capacity by more than 50% because they need 6 feet between each table.
Right.
Now we have been on for how long now? Over an hour. We've answered a lot of questions. I always feel bad because I try to get through as many questions, but Peter, I don't want to take up more of your time.
No, and I'm getting hungry, Jeff.
Everybody, I think we are gonna cut it off here. Thank you, everybody, for participating. Peter, thank you so much. This was awesome.
I wanted to just thank the viewers and the people that asked such great questions. And one of the things I say is that, I think so many Americans have done such a wonderful job with this. I'm so impressed at my fellow countrymen for asking good questions, for caring for their neighbors, for wearing masks. There's a lot of signs of optimism and hope here. And for the most part, I think, I've been pretty impressed with my country in terms of how we've dealt with this.
I agree. People have done a great job. And, I think that we just need to look out for each other.
Look out for each other.
We are going to get through this. Realize that, we don't have all the answers and try to give each other a little bit of a break and understand that, people are scared. Sometimes when we are in tough positions, we don't maybe act as well as we might want to. And sometimes your friends and people may say things that seem a little bit outrageous, but understand where they're coming from and, give each other a little bit of an extra break and, realize that it's a tough situation for all of us and we are going to get through it. And I do want to give a shout out to my daughter, Addie, who's been feeding us questions here.
She's doing great.
Thank you very much, Addie. And we want to give a shout out to Dr. Bream and his wife, Jennifer. I think she was going to C-section at 6 p.m. today. So it's her first child. Congratulations.
Very nice.
And Peter, again, thank you so much for participating.
My pleasure, Jeff. Thanks for having me.
At some point.
Absolutely.
And again, the intern, if you guys think, Peter, how many books have you written? This is your 5th?
This is my 5th, first to be published, but I've got 2 more coming out. So I'm trying to make a little bit of a sideline to it, Jeff.
And I'm trying to convince Peter to help me write a book too. So.
And I'm happy to do it.
Awesome, man.
Let's go. Cheers.
To Lisa as well.
All right. Thanks, Jeff. Bye-bye.
See ya. All right. Bye. Good night, everybody.
Hello?